Live from Boston, my name is Emilio Madrigal, and today is September 29, 2020. I am joined by my good friend and colleague, Rafat Manan, who is in Philadelphia right now. Today, we're excited to have a pediatric pathology lecture that's going to be delivered by Dr. Pierre Russo, who is a professor of pathology and chief of the Division of Anatomic Pathology at Children's Hospital of Philadelphia. Dr. Russo's talk is titled Neonatal Cholestasis. As always, please feel free to post comments, questions in the Facebook and YouTube chat windows, and we will make sure to pass those to Dr. Russo towards the end of the lecture. And so with that short introduction, I will pass over the microphone over to Dr. Russo.
All right. Well, thank you very much for the introduction. And today, the title of the talk is An Introduction and a Diagnostic Approach to Neonatal Cholestasis. And really, this is intended mainly for the general pathologist who can occasionally, or maybe fairly frequently, see some of these samples. So the objectives of the talk is to discuss the diagnostic workup of the cholestatic infant, to discuss the triage of the liver specimens. And because, it's so important to realize that the histologic features of the developing liver change in the infant, and to discuss the salient features of the developing liver and the relationship to findings in the liver biopsies of cholestatic infants. And finally, to discuss what, in my experience, are the major histologic patterns that are observed in liver biopsies from cholestatic infants and their differential diagnosis. And that's really a point that I want to emphasize, because certainly the practice here in Philadelphia is that we frequently usually get the liver biopsy before any diagnosis is established. So you might not be able to make a precise or a specific diagnosis, but you can give the pediatrician a differential diagnosis of the pattern that you're seeing, and thus orient their further evaluation and treatment. So when we talk about pediatric liver disease, and if you listen to any pediatric pathology pathcasts, you'll hear that phrase over and over again: children are not little adults. And even though many diseases that you see in adults are also seen in pediatric patients, and I've enumerated some here, there are some diseases that are unique to pediatric hepatology, or pediatric pathology in general for that matter, or have onset mainly in the pediatric age group. And here, neonatal cholestatic disorders is one such group of entities which are fairly unique to pediatric pathology and not seen in adults. And of course, developmental and metabolic disorders, which are typically seen in pediatrics. But today, we're focusing on neonatal cholestasis. So, let's start with a few basic definitions. So jaundice means there's elevated unconjugated or conjugated bilirubin, and it becomes clinically evident, the skin or the mucosa, when the total bilirubin is greater than 2.5 to 3 milligrams per deciliter. Now, cholestasis means reduction of bile flow from the liver, resulting in retention of biliary substances within the liver. And cholestasis is almost always defined by conjugated hyperbilirubinemia. So remember that you can be jaundiced and not cholestatic. But when you're cholestatic, you are jaundiced. And conjugated hyperbilirubinemia is defined as greater than 1 milligrams per deciliter, and that's relatively recently published guidelines by the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition. And hepatitis, of course, we mean inflammation of the liver. Now, it's important to realize that about 15% of neonates can develop jaundice, and I'm sure that you've all had experience looking at newborns, whether in your family or patients or whatever in your hospital, and newborn wards, and seeing fairly high number of jaundiced infants, often under the Bile light. So 15% of neonates develop jaundice. It's a frequent problem in neonates. But what you have to be able to distinguish is between physiologic versus pathologic jaundice. Fortunately, the vast majority of cases of neonatal jaundice are so-called physiologic jaundice. And that's usually due to immaturity of the conjugation system, and it catches up after a few days to several weeks. It's common and nearly never dangerous, and it's really defined by unconjugated hyperbilirubinemia. On the other hand, pathologic jaundice, which is cholestasis with a few exceptions, which is defined by conjugated hyperbilirubinemia, is an emergency with potential for fatal outcome and chronic disease, and it's never normal and needs to be worked up diligently. Now, if we look at unconjugated hyperbilirubinemia and look at the differential diagnosis, physiologic jaundice, as I mentioned in the previous slide, is by far and away the most common cause of unconjugated hyperbilirubinemia in neonates, and that usually resolves without any problems. Unconjugated hyperbilirubinemia can also be due to bilirubin overproduction, as in hematomas or hemolysis. It can be due to diminished bilirubin uptake, as in right heart failure. And there are very, very few rare disorders, inherited disorders of unconjugated hyperbilirubinemia that are Crigler-Najjar and Gilbert syndrome, which are due to deficiencies in this enzyme uridine diphosphate glycosyltransferase, which conjugates the bilirubin. And probably today, the Crigler-Najjar type 1 and type 2. Type 1 has the most severe form. Type 2, there's some residual enzyme activity. And Gilbert syndrome affects the same gene, but it's not a mutation within that gene, it's mutations within the promoter gene. And what I was going to say is that kernicterus is fortunately something that we see very rarely these days. It used to be much more common with hemolytic disease of the newborn, but Crigler-Najjar type 1 is probably still today a cause of kernicterus. And if you have a liver biopsy in a case of Crigler-Najjar or just about any unconjugated hyperbilirubinemia, the liver biopsy is fairly bland, and what you're going to see is an accumulation of bilirubin. Can people see my pointer here on the screen? It's accumulation of bilirubin pigment within the canaliculi of the liver without much in the way of significant inflammation. And this is an example of kernicterus from a case of Crigler-Najjar, where we have this yellowish discoloration of the central nuclei, as we used to see, say, in hemolytic disease of the newborns, which fortunately is much less common. When we talk about the differential diagnosis of neonatal cholestasis, it is the greatest of any age group. And there are over about 100 different etiologies that can lead to neonatal cholestasis. And the guiding principles for evaluation, given that there are so many etiologies and many are complex, rare metabolic diseases, some of which have new and effective therapies. So for the clinician, the initial evaluation of the cholestatic infants is designed to find out what are the dangerous and treatable conditions, what are the more common conditions, and what patterns in the biopsy or the biochemistry that provide clues for specific etiologies. So when we talk about etiologies of neonatal cholestasis, I have these two pie charts over here. The one on the left is from a study of over 1,000 patients that was published at King's College Hospital in London in the late 1980s. And on the right is a pie chart from the Children Network, which is essentially a consortium of pediatric hospitals in the US, about 16 pediatric hospitals in the US and Canada, with a focus on neonatal cholestasis. And so this is from about 3,000 cases. Now, two things to observe. Number one is that biliary atresia, both on the left pie chart and the right pie chart, is by far the single most common cause of neonatal cholestasis, accounting for anywhere between 35 to 40% of cases. And that really has not changed in the last 30 years. The thing that has changed more recently, however, is if you look at the orange portion of the pie, that is the idiopathic. Back in 1989, the idiopathic causes were just as frequent as biliary atresia. Today, though, with the advent of better diagnostic modalities and more frequent application, especially of genetic studies, we're able to reduce the percentage of cases that are idiopathic. We're better able now at identifying cases of Alagille syndrome. And you see that on the top of the pie chart, there are disorders that have appeared that did not appear in 1989. For example, the progressive familial intrahepatic cholestasis, which we'll touch on, bile acid synthetic disorders, and mitochondriopathies, which have been delineated in the last 30 years. So as we apply further and further genetic analyses and more sophisticated studies, presumably we'll be able to cut down further on the idiopathic forms. However, it is true that many of these cases today still remain idiopathic. So I mentioned before that it's important to uncover those critical etiologies for which early treatment improves outcome. And I've bolded here, for example, biliary atresia, okay? Biliary atresia, it's important to make that diagnosis as early as possible, because the earlier you bring these children to what's called a Kasai portal neurostomy, and I'll explain that in a few slides later on, the better the outcome for these kids. If you have extrahepatic obstruction of any kind, a stone or a tumor, you need surgery. Galactosemia. Galactosemia is a deadly disorder, which can lead to cirrhosis, sepsis, and death within the first year of life. You make that diagnosis, and the treatment is very simple: lactose restriction. Bile acid synthetic defects. If you manage to make the diagnosis early, and some of these can have devastating effects on the child, the treatment is very simple. You simply give the child normal bile acids to decrease the formation of toxic metabolites. Sepsis, urinary tract infection, give antibiotics. Tyrosinemia, the clinical picture of that disease has changed completely in the last few decades with the use of this inhibitor called nitisinone. So how does the clinical evaluation of these children proceed? Well, of course, like anything else, you need a good history, family history, onset of the disease, physical exam. You look for any dysmorphisms that could alert you to this being an Alagille syndrome, heart murmur, liver size, spleen size. And then there are what I call tier 1 studies, which are fractionated bilirubin, liver enzymes, alk phos, albumin, cultures, torch serologies. And these tier 1 studies can be done in any good community hospital. Then the tier 2 studies, which are really the imaging, ultrasound, HIDA-scan, specific metabolic investigations, and gene testing and liver biopsy, these should preferentially be done in pediatric centers that have experience with these studies. So going back, one of the most important enzyme measurements that we can do in cholestatic infants is the gamma glutamyl transferase, GGT levels. Now, because if a patient is cholestatic with low normal GGT levels, this brings up a whole group of relatively rare but still important to pick up disorders such as bile acid synthetic disorders and the progressive familial intrahepatic cholestasis, whereas practically everything else, and just about everything else in adult hepatology, results in a high GGT cholestasis. And the reason that is that gamma glutamyl transferase is an enzyme that sits on the outer portion of the membrane of the hepatocyte canaliculus, the hepatic canaliculus. When it's in prolonged contact with bile acids, it is eluded from the membrane and black flows into the plasma. So if you have patients with normal or elevated bile acids, you will have elevated GGT levels. However, if you have, in the case of the disorders that I've outlined on the left, when you don't have normal bile acid levels in your bile, that GGT is not eluted from the membrane, and there is no concomitant increase in the serum levels of GGT. So GGT levels are an important clue, diagnostic clue, in the workup of the cholestatic infant. Now, ultrasound is also a modality that is used frequently in the evaluation of the cholestatic infant. It's very useful in the identification of choledochal cysts and the identification of bile duct stones and identifying spontaneous perforation of the common bile duct, and in abnormal findings that can point to so-called biliary atresia with splenic malformations, that is, associated malformations such as polysplenia, heterotaxy, preduodenal portal vein. However, there are some other findings that may be potentially misleading. For example, lack of or echogenicity of the gallbladder, diminished size or absent gallbladder, lack of duct dilatation. And what I've illustrated on the right is the so-called triangular cord sign, which is believed to be due to fibrosis just north of the portal vein, which has been touted as being a reliable finding in biliary atresia. But you know, the literature on this is equivocal, and certainly at CHOP, our hepatologists don't put full faith in there. Now, the same thing goes with the hepatobiliary scintigraphy or the HIDA scan. This is when a contrast material is injected into the vein of an infant. It's picked up by the liver. In the normal state, it's picked up by the liver and excreted into the small bowel, usually within 20 to 30 minutes. So in the case of when excretion is present, when the liver picks up the dye, when the liver excretes it into the duodenum, that practically excludes biliary atresia. However, in cases where there is slowed excretion or absent excretion, that's not diagnostic because it could be biliary atresia, but any intrahepatic disease that can slow up uptake may slow down excretion. So a positive Decida scan when there is excretion is useful, but a negative Decida scan when there is no good excretion, it's not as diagnostically useful. Finally, operative and endoscopic cholangiography. For the diagnosis of biliary atresia, the intraoperative cholangiogram is still considered to be the gold standard. Now, and I've illustrated here the bottom picture. What happens with an intraoperative cholangiogram is the surgeon inserts a dye with a syringe into the gallbladder. And in the normal state, which hopefully shouldn't happen too often intraoperatively, but in the normal state, that dye is quickly excreted via the cystic duct and the common bile duct into the small bowel, into the duodenum. And also, it also opacifies, you can see these thin strands, also opacifies the intrahepatic bile ducts. On the other hand, in a case of biliary atresia, which I illustrated in the top picture, the surgeon inserts the dye into the gallbladder, and the dye goes nowhere. It doesn't appear into the bowel, nor does it opacify the intrahepatic biliary tree, and that's considered to be the gold standard in the diagnosis of biliary atresia. Now, sometimes, and I'll talk about that a little later on, there can be difficulties with some cases of Alagille syndrome. I mentioned ERCP. This is not a technique that is used at CHOP. It's not widely available. In infants, it's technically difficult. It's rarely therapeutic. So I think today we still use the operative cholangiogram. So the other thing, and that affects just about, I'm sure you're aware, every area of pathology, is the changing genetic landscape of pediatric liver disease. So, until recently, there were really 5 main genes of interest, and the workup of these patients was either single gene testing or limited panels. But with the current era of genomic diagnostics, there's an increasing yield with new technologies using gene panel or exome sequencing. There's identification of new disease-causing genes, and this, as I mentioned in one of the early slides, that seems to have cut down on the idiopathic cases. But however, as we identify new genes, so the exome is not, the genetics is not all the answer, because we have to correlate these findings with the clinical and the histologic phenotype. So it's not enough nowadays to discard the liver biopsy and just do the genetic testing. You have to be able to correlate that with the phenotype. Also, one important area of hepatology, be it adult or pediatric, that we're finding out with these new techniques, is we're identifying genes as disease modifiers. For example, we know that patients who are heterozygous for the SERPIN-A allele, the Z allele, that's the one when you're homozygous, that results in alpha-1 antitrypsin deficiency. But if you're heterozygous for a mutation in one of those alleles, that may modify the course of another disease that you have, such as cystic fibrosis, for instance. So now we're recognizing these genes that act as disease modifiers. So you look at this next image and you say, "Oh my gosh, this is really difficult to understand." But we can follow it, and it has a certain logic to it. So we have a child who is cholestatic, and we do the tier 1 testing, liver function tests, alpha-1 antitrypsin levels, PI typing, thyroid hormone determinations, urine cultures, newborn screening results. And if you get a specific diagnosis from these basic tests, then good, then you can go ahead and treat. However, if you do not get a diagnosis from these so-called tier 1 tests, then that's where examination of the levels of serum GGT are important. Because if you have a low or normal serum GGT, then what you should try, and what the clinician should try and eliminate, is a possibility of a bile acid synthetic disorder. And there, they would send urine for bile acid mass spectrometry. And if it's abnormal, you can make a diagnosis of bile acid synthetic defect and supplement the child with normal bile acids to prevent the formation of toxic bile acids. However, if that's normal, then you go back and do an ultrasound. And as in a case with a high GGT, you do the ultrasound. If you find a cyst or a stone, well, that means you take the child to surgery. However, if the ultrasound is normal or non-specific, you may follow that with a HIDA scan. If the HIDA scan shows excretion, that means you've ruled out biliary atresia, so you've got time to do a more extensive workup. At this point, you may decide to do a liver biopsy or do gene sequencing. However, if you have a non-excreting HIDA scan, that's when the diagnosis of biliary atresia is still in play. That's when a liver biopsy, certainly in our institution, would be considered mandatory. And if you have obstructive features that I'll illustrate shortly, this would lead to an intraoperative cholangiogram and possibly a Kasai portal neurostomy. However, if the liver biopsy is not consistent with an obstructive pattern, gives you a picture of giant cell hepatitis, that's when, again, you may need for further workup. All right, so this leads us to the question of the liver biopsy, why and when. So it's believed to this day that the liver biopsy remains the most accurate of the available diagnostic tests for biliary atresia. And remember that the orientation of the testing is to exclude or diagnose as rapidly as possible biliary atresia, because these children need to be taken to the OR as soon as possible. So it remains the most accurate of the available diagnostic tests with the best sensitivity and specificity. And according to NASPGHAN, it is still a recommended procedure, and it's mandatory in most pediatric hospitals prior to taking an infant to the operating room. However, there are mitigating circumstances. For example, if in some hospitals would require a child to be administered general anesthesia to do a needle biopsy, so then the clinicians would be loath to administer general anesthesia to a child to do a needle biopsy and follow that up a day or so later with general anesthesia to do an intraoperative cholangiogram. So because the risk of anesthesia is not negligible in infants. Also, we have to recognize that the complication rate, namely bleeding, of a needle biopsy in infants is greater than that in older children or adults. So you've got to balance the use of the needle biopsy with these considerations. But in our hospitals, certainly, and in most pediatric hospitals in North America, a needle biopsy is done prior to taking a child to the OR for an intraoperative cholangiogram. Now, how do we handle the liver specimens? So, of course, we're talking about needle core biopsies, percutaneous, or more rarely transjugular. So, as you know, core biopsies go by gauge, and the higher the gauge, the lower the diameter. So 16 gauge needle biopsies are 1.6 millimeters in diameter, usually a centimeter or so in length. 18 gauge, 1.2 millimeters in diameter. Now, we really don't recommend the higher gauge, like 20 gauge, because those tend to fragment, especially in the portal areas or in areas where there's fibrosis. So a fragmented liver biopsy is not very, very useful, especially in making a diagnosis of biliary atresia. So other types of biopsies, wedge biopsies is what you usually get at the time of laparotomy. And of course, we don't have time to talk about partial hepatectomies or explants. So what happens with once we get the needle core? Well, so remember that the 116 gauge core, which measures about 2 centimeters in length, weighs about 15 milligrams. And sometimes we're asked, should we freeze for metabolic studies? Now, the problem is that certainly in our institution, most pediatric institutions that I'm aware of, metabolic studies on frozen liver require 50 to 100 milligrams. That means that you would need at least 3 cores of tissue for metabolic studies. So I don't think most clinicians would be willing to take more than 3 cores of tissue. So in our cases here, we don't freeze any of our cores. However, we do submit perhaps a small piece at each end for electron microscopy. Cultures, we rarely do cultures unless the clinician asks us specifically if cholangitis is suspected. And remember, and that especially applies to older children, iron or copper determination in liver requires 1 centimeter core, fresh or formalin fixed, paraffin embedded in a metal-free container. Now, in our institution, we place the cores in specifically designed biopsy cassettes that have this very, very thin mesh. The reason for that is that other institutions simply wrap their cores in some sort of filter paper. We've had a number of unfortunate incidents. I'll be honest, when the next morning, the technician would take the cassette out of the processor and open the cassette and open the filter paper and lose the biopsy sample. So we prefer to have these specifically designed biopsy cassettes. We use overnight routine processing for most cases. We know that in an emergency, that processing can be compressed to 6 hours, but we use that mainly in the setting of transplant biopsies for same-day turnaround. So what are the routine stains that we use in liver biopsies in cholestatic infants? Well, we always do 3-level stain with H&E. Usually we do trichrome, either Gomori trichrome or Masson trichrome. I prefer Gomori trichrome. We usually do a PAS with diastase, and then reticulin, iron, or copper stains as needed. And then immunohistochemistry, we'll see that with a lot of cholestatic diseases, it's useful to use some biliary markers, either cytokeratin 7 or cytokeratin 19. In selected cases, we also have a panel at CHOP of antibodies against canalicular transporter proteins. That's especially in the categories of progressive familial intrahepatic cholestasis, and we'll outline these a little later on, and some intercellular junction proteins. But we don't use that in every case, but only if there are clinical indications or if the workup suggests the possibility of these disorders. So I'm going to make a little segue here and talk about the developmental changes, because it's so important to realize that the histology of the liver changes with age, especially in the premature neonate. So you have to be aware of what these developmental changes are and how they can affect your diagnosis. So remember that the liver develops as an outgrowth of the foregut endoderm at about 4 weeks. By about 6 to 7 weeks, a definitive vascular pattern is established in the liver. And around 10 weeks or so, specialized hepatoblasts at the rim of the portal area, so-called ductal plate, some of these hepatoblasts develop cholangiocytic features, namely, they start to stain with cytokeratin 19. And what happens is at the ductal plate, there's a progressive development of the bile duct, so that you have a one layer of these hepatoblasts with cholangiocytic features that develop earlier on, and then it becomes bilayered, and then a lumen develops, and then gradually these structures with lumens become incorporated more centrally into the portal tract, whereas the rest of the ductal plate disintegrates. And that's illustrated here. This is from a liver in a 14-week-old infant. And you can see that at the edges of the portal area, the so-called ductal plate, there are this bilayered, focally bilayered ductal plate, which is going to lead to the bile ducts eventually. So it's so-called a ductal plate here. Now, as the fetus advances in age, and you can see here these two portal tracts from a 16-week fetus, the one on the left is still largely in ductal plate, complete ductal plate configuration, but the one on the right, some of these ductal plate elements have formed bilayered structures with lumens that begin to be incorporated more centrally into the portal tract. And as the fetus ages, by the second trimester and certainly by the third trimester, you have gradual incorporation of these structures, what will become the bile ducts, more centrally, closer to the hepatic arteries, and the rest of the ductal plate, as we can see with these cytokeratin stains, the rest of the ductal plate disintegrates. Now, it's important to realize that this process of development of the bile ducts from the ductal plate is a process that occurs centrifugally. That is, it develops in the largest centrally placed portal tracts first, and then extends to the more peripheral portal tracts. And it even occurs up to 1 month after birth. So that it's entirely possible that if you get a needle biopsy from a premature infant, that the portal tracts that you are evaluating may still be in development, so that you could theoretically make a false diagnosis of bile duct paucity if you're not aware that this is a liver biopsy from a premature infant that is still in development. Now, we have a category of diseases that result from persistence of the abnormal persistence of the ductal plate, so-called ductal plate malformation. And this is the whole group of fibropolycystic diseases, such as autosomal recessive polycystic kidney disease and others, which we unfortunately don't have time to go into here, but you can see this abnormal persistence of ductal plate elements in these livers. Now, another thing that changes in the fetal liver is extramedullary hematopoiesis. Remember that the second trimester liver is the most important hematopoietic organ in the body. By the end of the second trimester, the bone marrow has largely taken over. So in extramedullary hematopoiesis, there's kind of a segregation pattern, whereas in the lobule, we mainly see sinusoidal, or we mainly see in erythropoiesis in the sinusoids, whereas in the portal tracts, we typically see myelopoiesis. At any rate, this extramedullary hematopoiesis regresses as the fetus ages, so that it practically disappears by 36 weeks of age. Now, it's important to realize, however, that any time an infant liver sustains injury of any kind, the liver may begin to be hematopoietic again. It seems to be a primitive response of the liver to injury, so that extramedullary hematopoiesis is very frequently seen in injured livers in infants up to 6 months of age. And that can be misinterpreted as inflammation, but you have to look at it carefully. It's actually erythropoiesis in the sinusoids and myelopoiesis in the portal tracts. It is, as I say, it is a primitive response of the injured liver, and it is not specific to any diagnosis. The reticulin framework also matures and develops with age. In the 16-week infant, you see you have liver cords of multi-hepatocytes in thickness. As the fetus matures to a newborn, your hepatic cords are better developed, but there's still usually a couple of hepatocytes in thickness until in the child you develop the single hepatocyte cord layer that we typically see in adults with the reticulin stain. A couple of other caveats: if you happen to do an iron stain in the liver of a young infant, it's not unusual to see some iron staining in the area of the portal plate. That can occur up to 3 to 4 months of age normally. So it doesn't mean that you're dealing with an iron overload disorder. Same thing with copper accumulation. Copper accumulation, especially in periportal hepatocytes, is a frequent concomitant of many cholestatic infant diseases, and it doesn't mean that you're dealing with a primary copper handling disorder. Another thing that's important to realize is that the histologic appearance of disease may change, of some diseases may change as the child gets older. For example, this is a case of alpha-1 antitrypsin deficiency. On the left, this is alpha-1 antitrypsin deficiency in a 10-year-old, and you see the readily observable PASD positive globules, mainly in the periportal hepatocytes. On the other hand, you look at the 6-week-old infant with a proven diagnosis of alpha-1 antitrypsin deficiency, you look at the panel on the left, these globules are not really apparent. And if relying on these features to make that diagnosis, you might not be able to make that diagnosis because these globules are just not seen in the infant. The same thing goes with metabolic diseases such as Niemann-Pick type C. On the right is a liver biopsy from a 10-year-old with Niemann-Pick type C, and you see your foamy reticuloendothelial cells. The liver biopsy from this child with Niemann-Pick type C, the 2-month-old, however, doesn't show the same features at all. You don't see the foamy reticuloendothelial cells. What you see is an overabundance of PASD positive staining Kupffer cells. So you've really got to suspect that pattern to make a diagnosis or to suggest Niemann-Pick type C, because if the foam cells that you would see in an older child are just not apparent in the infant. All right. So what are the major liver biopsy patterns that we observe in infantile cholestasis? And I grouped them into 3 major groups in my experience: obstructive, giant cell hepatitis, and bile duct paucity. So the obstructive pattern is illustrated here. This is when you have portal fibrosis, portal tract expansion, bile duct proliferation, and frequently the retention of bilirubin pigment within these proliferating bile ducts. And this is from a 5-week-old with biliary atresia. So this is the typical obstructive pattern. And in the workup of the cholestatic infant, if you see this pattern in a liver biopsy, you have to strongly suspect that this child has biliary atresia. Now, when we talk about biliary atresia, the incidence worldwide is quite variable. In the U.S., it's about 1 per 8,000 live births. It's about 1 per 4,000 to 5,000 in Southeast Asia. But whatever, it is the most frequent indication for liver transplantation in children worldwide. It's been divided into several clinical types. The isolated, or what used to be called the perinatal type, is the most frequent. And this is the one that's missed because these infants are frequently kind of normal at birth. They appear normal, and there's a jaundice-free interval after birth, and there are no other abnormalities, but they develop jaundice at several weeks of age, clinically recognizable jaundice. Then there's a syndromic form of biliary atresia, splenic malformation, which is about 10% of cases in which these children are frequently jaundiced from birth, and they have the laterality or the abnormalities that we mentioned before: asplenia, polysplenia, situs inversus. There are also forms of biliary atresia with other types of malformation. There are non-laterality malformations that can be mainly genital-urinary tract anomalies. And then there's a cystic form of biliary atresia that can be mistaken for colorectal cyst, and I'll illustrate that a little later. So biliary atresia, we've been looking at disease for over 100 years. The etiology is still unknown. There are various hypotheses that we don't really have time to get into here. The point with biliary atresia is that biliary drainage affected by Kasai port orostomy is crucial before 4 months of age, because if these children are untreated, cirrhosis develops usually before 6 months of age. There's a whole debate that's gone on whether these children should not go on to primary liver transplantation, but we don't have time to get into this. But the practice in most countries is that these children should undergo a Kasai port orostomy because it's difficult to do a liver transplant in a 2 or 3 month old, a lack of available donors. Whereas if you do a Kasai port orostomy, that buys you time to do a liver transplant when the child is older. So the Kasai port orostomy is named after the Japanese surgeon who devised it. And this is an illustration from one of our surgeons at CHOP. The atretic area of the biliary tree is identified. It is removed, and then that area is the residual portal area is shaved, and then a Roux-en-Y loop of small bowel is brought up to that shaved area of the portal tract and a direct anastomosis, hoping that the residual bile ducts at the portal area will drain directly into the duodenum. That's the point of the Kasai hepatoportinostomy. The specimens that we get from that are usually the entire biliary tree, and in most cases, the entire biliary tree is atretic. In some cases, varying portions of the biliary tree may be atretic, and the type 1 that I'm illustrated here, where the atresia is limited to the common bile duct, used to be referred to as the correctable form of biliary atresia in the older textbooks. That's because they could make, or the surgeons could make, a direct anastomosis between the proximal portion of the bile duct and the duodenum. However, that term has been abandoned. All these children with biliary atresia today undergo a hepatoportinostomy. So this is what the specimen that we get from a hepatoportinostomy look like. The surgeon typically identifies where the gallbladder is, the common bile duct is, and the fibrous plate. You can see it's a very shriveled specimen. And I'm just going back here. If we take a section from the fibrous plate, you can see that in a normal 40-week infant, at the level of the portal plate. On the left-hand side, you have a bile duct, in fact, several bile ducts, and these bile ducts may measure up to 400 or 500 microns in diameter. Now, this is a same section from a child with biliary atresia, a 2-month-old. And you can see at the same magnification, there are absolutely no bile ducts left, no observable bile ducts left here in the case of biliary atresia. Now, the remnant histology can have several features. On the left, we have a complete fibrous cord with total obliteration of the bile duct. On the extreme right, we still have an observable lumen, but you see it's injured and it's inflamed. As in the middle here, you can see various small biliary structures and probable peribiliary glands, but in a background of in a fibroinflammatory background. Now, practically all of the children following a Kasai hepatoportorostomy will require a liver transplant at some point. Now, this may vary. In some cases, you can delay the transplantation until the child is older. In fact, there are even reported cases of women giving birth with their native livers following Kasai portorostomy when they were infants. However, about 40 to 50% of children following a Kasai portorostomy, there is a failure of so-called failure of the Kasai, that is, there is lack of adequate drainage, so that these children will require a transplant before the age of 2 years. And you can see here on the lower right-hand side one such case, and it's not infrequent in these liver explant specimens to see a total lack of bile ducts. Whether that's a result of the Kasai portorostomy or natural progression of the disease is unclear. But on the top panels, you see that an explant from a typical case of biliary atresia gives you this biliary cirrhosis with a jigsaw puzzle appearance of the liver. Now, I mentioned that that it's important to make the diagnosis of biliary atresia as early as possible to bring these children to a Kasai portorostomy. The problem is that the average age at diagnosis in most countries, certainly in countries in the West, is still around 60 days of age, and that hasn't changed in 20 plus years. So several countries have tried to devise methods to improve the early diagnosis of biliary atresia. For example, Taiwan and Japan have developed these stool color cards that are given to the parents of the newborn, and they're told to contact their pediatrician if the infant stools fails to develop a proper color or becomes paler. And in those countries, there are a number of studies that have shown there's an improved 5-year survival rate with native liver. And there are feasibility trials of the stool color cards that are going on in Canada and other Western countries. Now, another method of improving the early diagnosis of biliary atresia comes from this very interesting study that was carried out at Texas Children's Hospital. And what they did is they identified patients with biliary atresia, and they looked back on their the serums of these patients, serums that they had saved from the first 72 hours of after birth. And what they found in this study, that in all the cases of biliary atresia that they looked at, in whom they had saved serum samples from 0 to 72 hours after birth, all of these cases showed elevation of conjugated bilirubin. So that it seems to indicate that in case of biliary atresia, even if the jaundice is not clinically apparent, these children may have elevated bilirubin levels right from the first few days after birth. And there's kind of two implications for this. One of them is that could you use serum levels at birth of bilirubin to follow these children up and make an early diagnosis of biliary atresia? But the other important light in terms of the pathophysiology is that seems to indicate that biliary atresia is probably an intrauterine event with liver injury manifesting by early elevation in conjugated bilirubin. Now, the obstructive pattern on the liver biopsy I mentioned is you're highly suspicious of biliary atresia, but you have to realize that there's a differential diagnosis. It is not exclusive of biliary atresia. And these are the disorders that can give a histologic appearance very similar to biliary atresia. Alpha-1 antitrypsin deficiency, choledochal cysts, early forms of Alagille syndrome, TPN, et cetera, et cetera. For example, this is a 2-month-old with alpha-1 antitrypsin deficiency. In fact, this child was worked up, but somehow or other the alpha-1 level was not determined, got a liver biopsy. The liver biopsy showed typical features of obstruction. This child was taken to the operating room to do a cholangiogram until somebody noticed that there was no alpha-1 level on the chart. They drew a stat alpha-1 level. The alpha-1 level came back 0, so the child was returned to the ward without an unnecessary procedure being performed. And as I told you, the PASD stain does not help here in orienting the diagnosis for alpha-1 antitrypsin deficiency because the globules are not apparent in an infant. Now, the other important differential diagnosis is choledochal cysts. Now, the age at diagnosis is very variable from infancy to older age. And you can see here that the choledochal cysts are divided according to this Todaro classification. So not important to go into the specific details here. The choledochal cyst wall, typically there's no area of atresia. It is a thick fibrous wall, usually without inflammation. The importance in making the diagnosis and treatment of the choledochal cyst later on in life is that the entire cyst has to be removed because these patients have a 10% lifetime risk of carcinoma. And this is from a case that was given to me by the pathologist Beth Firth at the Hospital of the University of Pennsylvania from a patient with cholangiocarcinoma in a choledochal cyst that was misdiagnosed, that was diagnosed later in life. Now, I mentioned that the cystic form of biliary atresia is an important differential diagnosis of the choledochal cyst because both may be detected antenatally as dilatations of the common bile duct. The difference is that in cystic biliary atresia, which are treated with a Kasai portal neurostomy, in cystic biliary atresia, there's always an area of atresia of the biliary tree somewhere along the biliary tract. And histologically, we find this peculiar sclerosis, subepithelial epithelial injury and subepithelial sclerosis. The gallbladder is typically also very atretic or atrophic in cystic biliary atresia, whereas in the choledochal cyst, typically the gallbladder is completely normal. There is no area of atresia, and a Kasai portal neurostomy is not done. It's simply removal of the choledochal cyst, and we see here the typical cyst wall that is of the choledochal cyst, which is fibrous, essentially non-inflamed, and no area of atresia. Now, parenteral nutrition can also, in the infant, induce changes that have an obstructive pattern with, and a 6-week-old here illustrated on the left, some portal tract expansion, bile duct proliferation, and bile duct plugging. And in a 4-month-old, that histologic picture is even more exaggerated. What I mean to say here is that it can be impossible for the pathologist to make or help make a diagnosis of biliary atresia in a child who has had parenteral nutrition for more than several weeks, because parenteral nutrition-induced cholestasis can give you very similar changes in a liver biopsy to biliary atresia. And the liver biopsy in that condition, in that case, may not be useful. And if clinicians strongly suspect biliary atresia in a child who has received significant parenteral nutrition, they probably should dispense with doing the liver biopsy and just go straight to the cholangiogram. How much parenteral nutrition can induce these changes? it's believed that they don't occur unless you have at least 2 weeks of parenteral nutrition. The point is that they can take weeks to months for it to disappear after you've taken the child off parenteral nutrition. The second major pattern is so-called neonatal giant cell hepatitis. And we can see here that there's a small portal tract on the left, and the portal tracts are not expanded, but the action here is totally within the lobule. We have multinucleated giant cells. We have a lot of extramedullary hematopoiesis here in the sinusoids. So this is the so-called giant cell hepatitis. And this giant cell hepatitis pattern is particular to infants because it's practically never seen in children beyond the age of 6 months. Occasionally, there is this entity called autoimmune hemolytic anemia, autoimmune hepatitis, which can be seen in children up to a year of age, but the giant cell pattern is peculiar to infancy and practically never seen in adults. Giant cell hepatitis is not a diagnosis. It is a pattern. It's a descriptive term because, as I listed here, there's a number of conditions that are associated with a giant cell hepatitis pattern, namely the torch infections. Occasionally, biliary atresia can show a giant cell hepatitis pattern, but there it's important to recognize the changes in the portal tracts. Metabolic disorders, panhypopituitarism, chromosomal disorders, et cetera, et cetera. And I'm citing this study that was published some time ago in American Journal of Surg Path by Torbenson et al. And these are etiologic findings in neonatal giant cell hepatitis, a 2-institution study. And you can see the follow-up of these patients with neonatal giant cell hepatitis and all the different diagnoses that can result in a neonatal giant cell hepatitis pattern. But as I said very early on, still to this day, about 50% of cases, despite a proper workup, remain idiopathic. Now, these children tend to have, most of the time, a fairly benign course. It is usually seen in premature infants, and it gradually goes away with age. It seems overall the idiopathic form of neonatal giant cell hepatitis seems to have a benign or a good outcome eventually. These children are very rarely biopsied. After that, we've had a couple of biopsies in these children later on in life, and they have essentially normal livers. Now, this is the situation, the neonatal giant cell hepatitis, where it's so important to correlate it with the serum GGT levels. And this is a case of bile acid synthetic defect with low GGT cholestasis. They can give you a neonatal giant cell hepatitis picture. There are at least 9 different enzyme deficiencies that have been described. The 2 most common and 2 most severe ones are the ones that affect the sterol nucleus. And this, as I mentioned, results in abnormal bile acids in the urine that can be detected by mass spectrometry of the urine. And here it's imperative to treat these children with primary bile acids, because in these cases, if you treat the children early on, it can be curative, and it can even affect histologic. It can even improve the histology, as illustrated here in these cases in this case of pre and post treatment. A very important category now of cases that can have a neonatal giant cell hepatitis picture with a low gamma GGT is this group of disorders called progressive familial intrahepatic cholestasis, which is a group of disorders resulting from defects in bile acid handling, either at the level of the canaliculus, of the canalicular membrane, or defects in the membrane itself. So here we have, for example, the bile salt exporter pump, a canalicular enzyme which exports bile acid from within the hepatocytes where it's formed into the canaliculus. Now, these are genetic disorders that have a clinical spectrum ranging from infrequent symptoms that are detected or that are found later in life to severe early onset disease. And the severe early onset forms have an autosomal recessive inheritance and are truly the progressive ones. So we can see here, for example, one of the first ones I would describe is the PFIC type 1, so-called Biler's disease, after the family in whom it was first described. This is a defect in this gene called ATP8B1, which is essentially a phospholipid, which flips the phospholipids from the inner to the outer membrane. And this results in a low gamma GT cholestasis because it affects the function of the canalicular transporters in that membrane. In early childhood can give you just a bland cholestasis. Some people by EM have described a granular bile. These children end up having fibrosis, and this is from a hepatectomy in a child that was 10 years of age. Now, there is a concomitant adult form of this disorder, which may be familiar to some of you, called benign recurrent intrahepatic cholestasis. These patients have a mutation in the same gene, but it's a mutation with much less severe, usually missense mutations with much less severe clinical consequences. Another very important low gamma GT progressive fermental hepatic cholestasis disorder is PFIC type 2, which results from a deficiency of bile salt exporter pump. This results in a neonatal hepatitis type picture. And here is where immunohistochemistry may be helpful, because you see in the normal, an immunostain against BSEP stains the canalicular membrane, whereas in a case of PFIC type 2 with a giant cell hepatitis phenotype, there is absence of staining of with the antibody. So that's in a case of a truncating mutation with severe early onset disease. Now, these children not only have cholestasis, but there's also a increased incidence of hepatocellular carcinoma and even cholangiocarcinoma early in childhood in this disorder. It's important to point out, however, that there is an important caveat with the immunostain, because in a patient with, say, a missense mutation, you may have a immunohistochemically reactive but physiologically non-functional protein, so that your BSEP stain or your immunostain against BSEP may be normal, but the patient still carries a missense mutation. So if you have negative staining, it's helpful, but if you have positive staining, it may not be, you have to be wary of that. It still does not eliminate that diagnosis. This is another form of progressive fermentary hepatic cholestatic disorder. This is one where there's a high gamma GT cholestasis level. This is so-called MDR3 disease, where the defect is in this gene called ABCB4, and that affects the export of organic acids, organic anions, into the bile canaliculus. These patients typically present somewhat later in life, at 18 months of age. They can have an obstructive type picture with portal expansion, bile duct proliferation. And again, here the immunostains may be useful. Above here, you can see at the top right, a normal control with a canalicular staining, and a patient with the defect here, a truncating mutation with absence of staining. And this table here summarizes the main clinical findings of the described group of progressive familial intrahepatic cholestatic disorders. And you can see how most of them can have a giant cell hepatitis type picture with rapid to variable progression. The last, as I'm slowly running out of time here, the last group of disorders, or the last group, is a so-called group of bile duct paucity. Now, normal bile duct to portal tract ratio is described as anywhere between 0.9 to 2, and in practice, that diagnosis is made when the bile duct to portal tract ratio is less than 0.5. Now, that implies that you've got to have an adequate number of portal tracts, and usually the figure is about 10 of them to to make a diagnosis with confidence. However, I think that in most needle biopsies from cholestatic infants, we frequently don't get portal tracts, and it's kind of difficult to make that diagnosis with confidence in most needle biopsies from infants. It's especially true if the needle biopsies come from premature infants, because as I explained earlier on, in the peripheral portal tracts, the bile ducts may still be in development, and you may not observe bile ducts, you may observe a ductal plate configuration, leading you to make a misdiagnosis of bile duct paucity. In 2020, in cases of bile duct paucity, the vast majority of cases in childhood in 2020 are due to Alagille syndrome, which I'll explain in a few slides. However, there are non-syndromic forms of bile duct paucity that are seen in various metabolic disorders, can result from congenital infections, and of course, in older children from inflammatory and immune disorders, biliary atresia, graft versus host disease, or can be drug-induced or, in rare cases, idiopathic. Now, Alagille syndrome is an autosomal dominant disorder. It's the most important cause of bile duct paucity in infants, in children. It's a multisystemic disorder that affects not only the liver, but also affects the heart, typically with right-sided heart defects and pulmonic stenosis, the skeleton, typically with butterfly vertebrae, which I've illustrated on the left, kidney, the vasculature, and the facies with peculiar triangular facies here that the geneticists can pick out very well, apparently, and then this thickening of the Descemet's membrane in the peripheral cornea. Now, the genetics of Alagille syndrome is the vast majority of cases, about 90% of cases are related to mutations in a gene called JAG1, which is located on chromosome 20p12. It's believed that about 60% represent new mutations in the proband. Now, about 1 to 2% of Alagille patients have mutations in the Notch receptor, and that's a small group of Alagille patients. They tend to be characterized by more severe renal disease. Now, JAG1 is a ubiquitously expressed gene that is extremely important in early development. They've tried to develop mouse models of Alagille syndrome, and homozygous deletions of JAG1 in mouse mutants are universally lethal. So patients with Alagille syndrome are heterozygous for mutations in JAG1. How mutations in JAG1 result in bile duct paucity in a patient is really unknown at this point. There are many hypotheses that we don't have time to get into. But the JAG1 and the Notch are part of this JAG1 Notch signaling system. There are families of ligands and families of receptors, so-called Notch receptors. What happens is that the interaction between the ligand JAG and the Notch receptor results in a cleavage of the intracellular portion of the Notch receptor, and that cleaved off portion moves to the genes where it inhibits differentiation of the cells. And this may be a hint as to why no bile duct development occurs in these patients, although the full mechanism is not fully understood. And the Notch is named after the fact that this system was identified in Drosophila, which had a notch in their wings. So bile duct paucity appears to evolve in Alagille syndrome, so that early on in life, in a 3-month-old, bile ducts may be present, but by the time the child is older, at the time of transplantation, you have the fully evolved bile duct paucity. And this disorder is also very peculiar in that there may be heterogeneity in the progression of the bile duct paucity, so that some portions of the liver may develop bile duct paucity, whereas other portions of the liver keep their bile ducts and may even hypertrophy, as in this case here, where you have hypertrophy of the caudate lobe with preservation of the bile ducts, whereas the rest of the liver is injured and has developed fully bile duct paucity. So in conclusion here, neonatal infantile cholestasis has a broad differential diagnosis. The aim of the diagnostic workup is to identify as soon as possible a number of critical etiologies, for example, biliary atresia, where early treatment is key. Liver biopsies play a critical role in the diagnosis of these disorders. And really, it behooves the pathologist to be familiar with the differential diagnosis of the patterns that he or she observes and be able to discuss with the clinicians the clinical implications of these various patterns. So I think I'll stop here. And
thank you so much, Dr. Russo, for this excellent discussion on neonatal cholestasis. There are a few questions for you online. I would try to read out to you. The first question is, how do you form the histopathology report of Kasai procedure specimen? And what's the importance of diameter of the ductules?
Can I ask you, is it possible for somebody to either read me these questions on my phone, because I'm having difficulty hearing through the computer, and I want to make sure that I understand the question correctly. Is it possible for you to phone me now and read me the question?
Do you hear okay now, Dr. Russo?
Not very well, no. So call me on my phone and I'll answer the question on the computer.
Okay, great.
I just want to make sure I understand it properly. Yes. Hello? Okay, and how do I do this? Okay, mute. Oh. All right, so the question was how to form the histopathology report of the Kasai pornerostomy, and the corollary to that question is how important is it to measure or to determine the diameter of the remaining ductules? Well, how we do it here is that we always have a wedge biopsy along with the specimen of the biliary tree. We describe the biliary tree as being either completely atretic or having areas that are non-atretic. We describe the degree of inflammation and the degree of fibrosis. We also describe the degree of portal fibrosis in the wedge biopsy of the liver. Now, in terms of the diameter of the bile ducts that are seen at the level of the portal plate, that's an extremely controversial subject. And there are studies that say either that the diameter is important in the outcome, or the diameter, measuring the diameter, has no significance in helping predict the outcome. It's really the age at which the Kasai operation is done and the experience of the surgical treating team. So I can tell you that there are arguments here for both sides. We are currently looking at that in the Children Network to see if the diameter of the biliary tree has any bearing. But there are arguments for both sides. And it's important to bear in mind also that the various studies that have looked at, there are many studies that have looked at that. And in many of these studies, the methodology of measuring, of determining the diameter or the size of these biliary remnants differs. So it's sometimes difficult to compare these studies with each other.
There is another question. I'm going to call you again.
So the question is, when do you suspect ductal plate malformation in a child with cholestasis? Well, I've illustrated in one of the earlier slides the ductal plate malformation. So this is where you have, usually in these cases, you have portal fibrosis, portal expansion, usually without any significant inflammation. And at the level of the limiting plate, that is around the portal tract, you have a whole group of abnormal ectatic ductal biliary structures right at the edge of the portal of the ductal plate. They're not so centrally located, but they're mainly at the edge of the ductal plate. And usually there's a clinical context. If you suspect that, most cases it's related to autosomal recessive polycystic kidney disease. So have the clinician make sure that they look at the kidneys to see if there's any abnormalities.
Here is another question for you, Dr. Russo.
Absolutely. Okay, so the question is, what is my experience with extrahepatic obstruction in Alagille syndrome and with paucity of bile ducts in biliary atresia? Okay, so let's tackle the first part of the question. As I mentioned early on, the intrahepatic cholangiogram can be misleading in cases of biliary atresia because in especially more severe forms of an Alagille syndrome, I should say, I'm sorry, I made a mistake here. But in Alagille syndrome, a percentage of patients may have a hypoplastic biliary tree. That can lead to, number one, an obstructive picture in the liver, and number two, if these children are taken to the OR for an intrahepatic cholangiogram, the intrahepatic cholangiogram may be obstructive. It may show a pattern or a lack of excretion similar to biliary atresia. And a number of these children, and there are some studies that have looked at that in the past, up to 10 to 15% of children with Alagille syndrome have had Kasai portoneurostomies on this basis. And there's not a lot of data out there, but it seems that children with Alagille syndrome who undergo a Kasai operation do worse than children with Alagille syndrome who do not undergo a Kasai operation. So bottom line is you want to avoid a Kasai. Now, how do you do that? Well, usually, certainly in our hospital, it's the constellation of other findings. Alagille syndrome, as I mentioned early on, is a multisystemic disorder. So you have cardiac findings, you have facial features, dysmorphism, you have skeletal findings, you have ophthalmic findings. So before doing a liver biopsy in a child who's cholestatic, they will look for these features. And if any of these features are found that are suspicious for Alagille syndrome, then they will try to avoid going down the route of a liver biopsy followed by a cholangiogram, because at this point, you may force the surgeon's hand into doing a Kasai, which you don't want to do. The reverse, the other flip side of that question is, what is my experience with biliary atresia with bile duct paucity? In biliary atresia explants, we see bile duct paucity, I would say, probably about 40 to 50% of our cases, all right? Now, as I mentioned, that in most of the time, that's in those children who have had a failed Kasai. The Kasai has failed and they never got good drainage, good biliary drainage. And these children undergo liver transplantation less than usually within 2 years of the Kasai. And it's very frequent to see in those explants a loss of bile ducts. Now, we've had a number of cases with, not that many, but for example, I can recall one case. of a child who was suspected of having biliary atresia. He was transferred from another hospital to our hospital. He or she was already 6 or 8 months of age, so it felt to be too late for a Kasai operation. He was transferred directly for a transplant. And when we got the explant, we saw on the explant, it was a cirrhotic liver, but we saw on the explant that there was a patent gallbladder. And a patent gallbladder should not occur in biliary atresia. So this led us to suspect that this may have been a case of Alagille syndrome that was mistaken for biliary atresia, because there had been a liver biopsy when the child was about 4 or 5 months of age that showed obstructive features. And sure enough, genetic analysis showed this child to have Alagille syndrome. So it's important to bear in mind that percentage of Alagille syndrome may present as biliary atresia.
One last question for you, Dr. Russo.
Pardon me?
Just another last question for you.
So the question was, how do you distinguish parenteral nutrition-induced cholestasis from biliary atresia? And I will say the very simple answer is, in any child who has had significant parenteral nutrition, it's impossible to distinguish biliary atresia from parenteral nutrition-induced cholestasis. Now, that has been looked at, and it seems that you have to have probably at least 10 days to 2 weeks of parenteral nutrition in an infant to affect liver changes that are similar to or that can affect obstructive type changes. The problem is that when and we have this clinical scenario that you allude to several times a year here at CHOP. They have a premature infant. They've given the infant parenteral nutrition. They remove the parenteral nutrition, and a couple of weeks down the line, this child is still cholestatic. Could this be biliary atresia? And at this point, I would say, by and large, a liver biopsy is not useful, because it can take weeks, if not months, for the cholestasis to wane after you've taken a child off parenteral nutrition. And if the clinicians suspect biliary atresia on clinical grounds, they may be better off going straight to an intraoperative cholangiogram rather than do a liver biopsy, which is just going to show obstructive features but cannot distinguish parenteral nutrition from biliary atresia.
Thank you so much, Dr. Russo. I think these were the questions that we had, and thanks a lot for your in-depth discussion on this very difficult topic, and I'm sure the viewers have benefited a lot. And you would be very happy to hear, Dr. Russo, that you had several hundred viewers from across the world, and I could keep track of at least viewers from 20 different countries, including viewers from as far as Myanmar, Bangladesh, Ukraine, Venezuela, Singapore, Germany, to name a few. And of course, we had a few viewers from US and India as well. And thanks to all of our viewers for your continued support to Pathcast. And if you like our lectures, please don't forget to subscribe to our YouTube channel and follow our Facebook page, and also follow our website, that is pathologicast.com, so that where you can get access to all the lectures which are organized by subspecialty as well as by the speakers. And you also, please don't forget to subscribe to our newsletter so that you can stay tuned with all the upcoming lectures. Our next lecture is coming up on Tuesday, so that is 2nd October at 8 a.m. Eastern Time, and we would continue our non-neoplastic lung pathology lecture series by Dr. Leslie and Colby, and the topic is additional patterns of lung fibrosis and inflammatory infiltrates in interstitial lung disease. Hope to see you all for the lung pathology lecture on Tuesday, and thank you so much. Thank you again, Dr.